Welcome to Medical Logistics 101, Pancreatitis Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Pancreatitis is an inflammation of the pancreas typically caused by premature activation of digestive enzymes inside the gland. This leads to local tissue injury, systemic inflammatory response, and in severe cases, multi-organ involvement. Two major forms: acute pancreatitis, where you have a sudden onset reversible inflammation, and then chronic pancreatitis, where you have a long-standing inflammation with irreversible structural damage, scarring. Symptoms, classic symptoms: sudden severe epigastric pain, pain that radiates through to the back, pain worse with eating, especially fatty meals, nausea and vomiting, abdominal distension, inability to get comfortable. Sometimes the patient will be pacing around the room, leaning forward, knees up to their chest. Exam findings: tender over the epigastric area, that's the upper abdomen, guarding on the abdominal exam, tachycardia, low-grade fever sometimes seen with it, hypotension in severe cases, that's a major red flag for me, gray Turner sign or flank ecchymosis, that is kind of a bruising along the flanks area. It's a rare and late finding. I've only seen it once. And a Cullen sign, which is a periumbilical bruising, rare and also a late finding, not seen very often. Causes, two big causes responsible for 70 to 80% of cases. Gallstones, where you have a transient obstruction of the pancreatic duct, often following a fatty meal. Alcohol, where there's heavy use or binge pattern drinking. Have seen it occur in even people with just a single episode of heavy drinking in susceptible individuals. Other causes include elevated triglycerides, medications, azathioprine, valproate, thiazides, which are often used for blood pressure management, GLP-1 inhibitors, which are currently in the news so much for weight loss and diabetes management, trauma, infections, and idiopathic, where we simply don't know what the risk factor was that they had the first episode of pancreatitis. Lipase, the key test. Typically, these will be greater than 3x the upper limit of normal. This is kind of the gold standard test for pancreatitis. Amylase, less specific, rises and falls quickly. Sometimes we obtain that one as well. CBC, or complete blood count. Leukocytosis, or an elevated white count, will oftentimes be seen. A complete metabolic panel, where we're looking at electrolyte issues and renal function. And liver function tests. Elevated ALT can point toward gallstone as being your potential culprit in these patients. And elevated triglycerides sometimes will be something we see with pancreatitis. I don't routinely get triglycerides in most of these patients in the ER setting. Imaging, CT of the abdomen pelvis with IV contrast is kind of our gold standard. Not always needed early if there's a known history of pancreatitis. Useful if diagnosis is unclear or the patient is not improving. Shows inflammatory changes, necrosis, fluid collections. Ultrasound, but not for diagnosing pancreatitis, but it is done to look at the gallbladder for gallstones or biliary dilation, which oftentimes is associated with pancreatitis. Possible mimics: these conditions could feel like pancreatitis but aren't. A perforated ulcer could certainly produce these symptoms. Biliary colic or cholecystitis, as I mentioned, with the gallbladder. Sometimes you'll see pain not only in the right upper abdomen, but also kind of the mid upper abdomen. Mesenteric ischemia, where the bowel isn't getting adequate blood flow. Not seen as often, but it's something you have to kind of keep in your mind. And then, very important, AAA dissection, abdominal aortic aneurysm dissection. This is one that you would have to catch it immediately upon the patient arrival. They would be in significant pain. The beauty of currently is that we use ultrasound in that setting, a so-called focused abdominal sonographic test, or FAST ultrasound, and it can quickly identify the AAA and the dissection right there by the bedside, and that's critical to catch it as soon as they arrive. Small bowel obstruction, it certainly can produce pain in the area of the upper abdomen. I typically see a different pattern of pain with the small bowel obstruction. It's more of pain tends to come in waves, comes and goes, and it's probably due to the peristaltic action of the bowel, but the pain tends to be a little different with small bowel obstruction than pancreatitis. Inferior mind, this is another one you'd have to catch it immediately upon arrival. This is upper abdomen pain, and as I've covered in my chest pain video, I will always get an EKG on any patient with upper abdominal pain, just because it can present this way in inferior MI, and it's one of those that you'd have to catch it immediately upon arrival when the patient is in your ER. Even a delay of 20 minutes, which is shorter than it's going to take for lab work or CTs or any of those things, delay of 20 minutes in catching an inferior MI would be devastating. So I get an EKG on these people as soon as they arrive. And of course, gastritis or just inflammation of the stomach, that's sometimes seen people that drink, which certainly would be a risk factor for pancreatitis, but also can have a viral gastritis. Red flags, hypertension, low blood pressure, that's a major red flag for me with pancreatitis patients. Tachycardia out of proportion to the exam, confusion or altered mental status, severe unrelenting pain, sign of organ dysfunction, renal, respiratory complications are developing from the pancreatitis. This is usually someone who's very sick. Increasing abdominal tenderness, inability to tolerate oral fluids. Any of these would be reasons I would potentially put someone in the hospital for admission. Pitfalls, assuming a normal lipase rules out pancreatitis. Early or late presentations can be misleading. I've certainly seen pancreatitis patients that had a normal lipase. Missing gallstone pancreatitis, especially in older adults or those without the classic right upper quadrant pain. Underestimating severity. Patients sometimes look okay early on in pancreatitis and then significantly worsen and crash later. Attributing the pain to gastritis and heavy drinkers. As I said, that's obviously a high-risk group. And of course, not considering triglycerides as a cause of the pancreatitis. As I said, I don't routinely check triglycerides sometimes in these patients when they arrive, but it is certainly something to think about and keep in the back of your mind. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.